Hi, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight's topic, Advanced Directives and Living Wills. What purpose do they serve, and how are they different, and the difference they can make in end-of-life decision-making, an important topic tonight. Tonight's guest is Dr. Michael Boucree, the Vice President for Medical Affairs in the Ochsner Health System. Dr. Boucree received his medical degree here in New Orleans. He's from New Orleans, from the Tulane University School of Medicine. He completed his internship and residency in internal medicine at DC General Hospital, part of the Howard University Medical Service Program. Spent most of his professional career in Flint, Michigan, holding various positions, and many of them leadership posts at the Northwest Medical Center and at the Hurley Medical Center. He is certified by the American Board of Internal Medicine and by the Certifying Commission on Medical Management as a certified physician executive. And it is our pleasure to welcome Dr. Michael Boucree to Hello Health. Good to have you with us on the program, Doctor.
Glad to be here with you.
Thank you for being here. So first-time guests all get asked this question. What was it, or who was it that first inspired you to be in medicine?
Wow. I remember as a student in grammar school, interestingly, seeing a picture of the oral cavity and the digestive system. I didn't become a dentist, but that's my earliest recollection of wanting to go into health programs. And from elementary school into high school, my family is in education, so I was a first-generation health student. Had to get involved in some programs to help me to understand what was this all about. So in high school and in med school, in college, I did the same thing and wound up going to Tulane, which was one of the sponsoring programs that I had gone to for a medical program also.
How did you become an expert in the topic we're discussing, an important topic tonight?
I wouldn't say expert, I'd say just sort of daily experience in doing this over several years. There are several recurring themes, working with the risk management team and our attorneys on many issues, and working with families, outpatient and inpatient, about this topic.
Very good. Well, we're glad you're here to educate people about this end-of-life decision-making and preparing for those decisions. So when we're talking about advanced directives, what are we talking about?
So advanced directives, the meaning is in the title, to direct what it is that you want in advance. It's a way that patients and their families can put into writing what it is that you want, but sometimes more importantly, what you don't want at a time when you can't speak for yourself. And so that's what we call advanced directives. In Louisiana, we also call it a declaration of your life's wishes.
Sounds like a living will, but is it? Is there a difference?
So it exactly is. It is a living will. In the state of Louisiana, it is a declaration of your living will, a written or an oral declaration, particularly if you fall under an irreversible condition and can't speak for yourself. An important aspect of that is when you're putting your words to writing, or putting your wishes to writing, or putting your will to writing, you don't have to have it notarized. It's just the fact that you're expressing that, and that it is communicated to someone, and hopefully that's someone that can witness to say that this is what Tom Bagwell says that he wants done, or what he doesn't want done.
And does it have to be in writing, or can it be verbal?
It can be verbal. Written, there's really no question about what you have written. Oral is sometimes subject to interpretation of what you heard me say, or what it is that you wanted to hear me say.
We have something in Louisiana called LaPOST. What is LaPOST?
So LaPOST is a Louisiana physician order for scope of treatment. And it's a way that you can, again, put down into writing. It's a very structured form, saying what you want, cardiopulmonary resuscitation, pressing on the chest, or you don't want that, medications that you want, medications you don't want, IV fluid hydration or nutrition that you do or you don't want. And that can be done on an outpatient basis, signed by you, signed by your physician, and that carries forward with you to any institution and can be your order for treatment. And it is modeled after an Oregon process called POST, P-O-L-S-T, but it has the same impact. It's a way that a family and patient can talk about what their life's wishes are. The patient can talk with his physician or her physician about what they want, what they don't want, reduce it to writing, and have it to be as an order when you go into the hospital. And the beautiful thing about that is that you may go to a hospital that I may not have privileges, but this document, according to the state of Louisiana, can be recognized as an order for treatment. The physician there would have to acknowledge that, but that is an order for treatment.
Looking at practicality, so under normal circumstances, I'm admitted to the hospital, the family's brought me there, or I've admitted myself, here's my paperwork. What about in an emergency situation? I'm in an accident, I'm brought to the closest hospital where, you know, where the ambulance has brought me. Where are these documents? Are they on file somewhere?
So that's a great question. For LaPOST, it is a document that you would have to carry with you, or someone have to carry. It is portable. Living wills, the same, but Louisiana does have a service where it can be filed with the state and put on file there. There is a small fee for that, but when you consider the impact of it, that fee is really very nominal. That once you do that, according to certain legalities and making sure that it's okay, you can file it with the state, and it will always be there. We can get it from there.
How does Advanced Directives, Living Wills, and LaPOST differ from what some people call healthcare power of attorney or durable medical attorney power?
So Living Will and the Advanced Directives that we spoke about simply say this is what I want to do, and may or may not have a witness, may or may not have someone else that I designate to speak on my behalf. A healthcare power of attorney or durable medical power of attorney, in that document, you state, in the event that I cannot speak for myself, this is the person whom I want to speak for me, and I am so directing them to do X, Y, Z, and Q. That document also is witnessed by individuals that are not blood relatives, individuals that are not subject to be an heir to your estate or anything. And when the person witnesses that document, they're simply witnessing that you, Tom Bagwell, you know, are the person is the person that's signing this. It's not, the witness is not saying that I agree with what he's saying. It's simply saying that you are Tom Bagwell. And you
I
are the
witnessed
person.
it. I saw it.
Exactly, exactly. So that's the difference between that. In those documents, healthcare power of attorney or durable medical power of attorney, you designate usually two persons to speak for you in the event that you cannot speak for yourself.
You've done this for yourself. I put you on the spot earlier. You've done this with your parents.
Yes.
So obviously you feel like this is important.
It is.
Why do you want our viewers to know this is important?
The first important thing is to have the conversation. It is so heart-wrenching to have someone in somewhat of an irreversible condition or a terminal condition and not to have had the conversation, because the conversation would be something about what would Tom want? What did he say that he wanted? Or what did he say that he didn't want? Because at that time it tends to be very, very emotional, and I'm caught up in my own emotion of what I want to see. And sometimes we're very selfish with that. I can't say it's inappropriate because it's what we feel, but we tend to tie into our emotion of what we want to see for mom, for dad, for husband, wife, or child. When in fact, what should be the guiding decision is what would this person want for themselves? If they could speak, what would they say that they want? So that's the important thing, that is have the conversation. And I can guarantee you, the first time you have the conversation, it is very difficult. The second time you have the conversation, it is very difficult. But it's having the conversation. And then you come to a point of understanding. I do want this, I don't want that. And then putting it to writing. I did it for myself. I thought it would be easy. I didn't get too far the first time. It took me about 3 times to get it reduced to writing. And then using a structured form really helped. I tried to do it freestyle, but then a structured form really helped me to do it better in terms of resuscitation, etc. And you don't have to have a terminal condition in order to do it. Again, it's the documentation of what it is that you would want in the event that you cannot speak for yourself and be under an irreversible or terminal condition.
You think part of the difficulty is us facing our own mortality? That would
Yes.
have to be part of it.
Indeed. Yes, indeed, that is. So the other importance is once you do that and you communicate that, another important person that needs to know that is your physician. Sometimes families have the conversation and may not speak to their physician. So if I'm the treating physician, I'd like to understand what it is that you want and don't want, so we can be of the same mind and thought. I do need to be a part of it, or we need to be a part of it because we have to consider it in the light of what your current condition is and what your prognosis of condition is and what can we expect, far along the way.
Do these documents need to be executed by an attorney?
So they do not. That's an excellent question. Having it executed by an attorney does help with making sure that there are certain things that are unambiguous and very clear, because remember, at the time that we are using this, you probably are not able to speak for yourself. So we are subject to understanding what it is that you were trying to convey. And sometimes you do go through legalese when it's executed by an attorney, but oftentimes it is very clear what is to be done, what is not to be done, and the what-ifs. Additionally, it also will designate who we should go to. We have what's called the lines of consanguinity, which means that if you are married, we go to husband or wife, and then child, and where your parents fit, your uncle and aunt, whatnot, where they all fit through there. So next of kin, we go through that, but when an attorney does it, it does have more clarity, but it does not have to. The important thing is for you to put your thoughts to writing, put it down on paper, and it does not have to be notarized.
Now, you mentioned that this was difficult even for you.
Mm-hmm.
Would you recommend a third party helping you walk through the process? So you said you tried to do it yourself, found it difficult, where there's a third party who might, kind of help move it along.
So interesting you said that, because after I wrote it, I brought it to a third party and said, tell me what it is that you read that I want to do.
Yeah.
And they actually read it and says, I have no idea. And I thought it was very clear, articulating this and that and other. And they were not in healthcare. And so that was very eye-opening to me. And after I explained it to them, they said, well, we understand now, but that's not what you have written here. Witnessing, we talked about a third party. Having witnesses to your document is important, again, because we want to know that it was you that have signed the document. Certain parameters we need to observe with that is that making sure that that person is not related to you, and making sure that person is not an heir to anything of your estate.
Does power of attorney give one decision-making authority for the patients for end-of-life situations?
Depends. It's a great question. Most of the time, the term power of attorney usually means for financial or business affairs, and that most oftentimes is executed by an attorney. There are some powers of attorney that may include something about health, and again, that is when it is written by the attorney is very specific. In general, a power of attorney means financial or business transactions. That's why we differentiate power of attorney from healthcare power of attorney or durable medical power of attorney. The latter two are very specific to healthcare and health conditions and irreversible conditions.
When do the documents themselves become applicable in day-to-day, the cases you're seeing?
Mm-hmm. So as long as you're able to speak for yourself, and can tell me what you want and you don't want, the document is not applicable. At the point in time that you cannot speak for yourself, or that you become subject to an irreversible condition, or you have clouding of your mental faculties and may not completely understand the person that you have designated as your medical power of attorney can step in, or the document would step in to guide the medical profession into what you
There are
want.
ever arguments over that? A
Yes.
family member who's in a hurry to get things over, and a doctor who says, no, Mr. Smith knows exactly what he's talking about.
Yes, and that goes to the point of oftentimes some family members or friends would like to see, I want to keep you here, or that's not what I would want for them to happen to them, or I think you should try X, Y, and Z. And you've clearly told us that that's not what you want, or in our conversations we know that is not what you want. And in the third scenario where ethically it probably is not the best, because the outcome, we do think about quality of life in terms of the outcome. What is it that you enjoy doing, then what you are able to do now, and what would your life be after this intervention that you're asking to be done.
So even for people who've done all this work, there are still going to be some problems that arise. What are some of the problems you have seen, without getting into any specific cases, obviously?
Sure. Some of the problems are daughter, son, was not aware that mom had executed this, let's say a LaPOST, and I can't honor that because I didn't know that they had done that, and I don't know that that's really what they wanted. Second is, I don't agree with that. The third is, there are therapies that are out there that I've seen on television that I know you all can try. One of the difficult things is sometimes, because there are therapies that are out there that can be done, it may not be the appropriate therapy for the patient that we're talking about. Those are some of the most common issues that arise.
Our guest tonight is Dr. Michael Boucree, and we're talking about advanced directives in living wills and the planning for that sort of thing. So I'm imagining this is not the type of thing you want to talk about after a terminal cancer diagnosis or after a serious accident. This is the kind of thing that should be done when everyone's thinking clearly. And before these sorts of decisions are going to have to be made, right? It
is best to be done when there is not that issue pressing, terminal condition. However, many times in practicality, that's when people start to think about their own mortality, is when something serious comes upon them or befalls them. That's when they start thinking about it. Having the conversation, just talking about the what-ifs, and what's important. That's another very important factor. I mentioned just a little while ago in terms of quality of life. One of the questions that we ask is, and I'm using you as an example since we're sitting together here, what is it that Tom enjoyed? What is it that he would like to enjoy if we were to do this? What is it that would be his quality of life? That's a very important question, and it's a very central question to when we're talking about certain interventions, particularly cardiopulmonary resuscitation or pumping on the chest. Because the survival for that is really in the 20%, 6 to 20%, depending upon where it is, depending upon the condition. So we don't take that lightly. It is a life-saving measure. But in certain instances where we know that you have a terminal condition, a metastatic cancer, or an irreversible brain condition, even though we have the ability to do that, it may not be the most appropriate thing for you, because what's going to be the post-resuscitation quality of life for the individual? Will it be the quality of life that they wanted?
What are the things that patients and families should consider when they're coming up with this sort of documentation?
So we oftentimes, the first thing that comes to mind, and we always talk about, of course, is what if the heart stops? What if breathing stops? So those are two important things. But the other things we need to consider are hydration, intravenous fluids, nutrition, surgical procedures. There is a standard of care that after approximately 2 weeks, 14 days being on a ventilator, we do need to do a tracheostomy to get the tube out of the mouth to put into the throat, depending upon what the long-term treatment is going to be. There's a procedure that we do to put a tube into the stomach in order to feed. Other things are antibiotics, medications to maintain your pressure, because one of the consequences in end of life is your pressure may decrease. We do have medications that will elevate it, but sometimes it is part of the natural course of illness or death that pressure will decrease. And heart rhythms. So all of these things that I just mentioned, hydration, nutrition, surgical procedures, heart rhythm medications, pressure medications, antibiotics are things that you should also consider. Do I want those? Do I not want those?
Based on everything you just said, does do not resuscitate or DNR mean do not resuscitate?
So do not resuscitate would mean that in the event that your heart or lungs stop, your heart stops beating, your lungs stop breathing, brain stops functioning, that we would not resuscitate. We would not bring them, we would not give you medications, we would not punch on the chest to resuscitate you. It does not mean do not care. We do everything appropriate for the condition.
Difference between DNR and comfort care.
Correct. So we continue to care for you, but we will not resuscitate. In comfort care, it means that we will not resuscitate and we will do everything possible to keep you comfortable, but we will not do any extraordinary measures. So in that, there are some families that choose just stop everything and we keep you comfortable. Pain medications, anti-anxiety medications are given. And again, it's a matter of comfort without doing anything extraordinary.
Palliative care is something you wanted to talk about tonight.
Yes. So palliative care it is a branch of medicine which has really come to life in the last several years because we are living with a lot more chronic conditions. Palliative care is specialized care for individuals with chronic conditions or terminal conditions. It does not mean do not care. It may include do not resuscitate. It may include comfort care. But it's a way of talking about your condition and how we can reduce any symptomatology associated with that condition, as well as what's the most that you can live your life in this chronic condition. One example would be someone who has COPD or a breathing condition, chronic obstructive pulmonary disease. It's very difficult to breathe. You may not be able to do the things that you were able to do 5 years ago. Through palliative medicine, sort of understand what's important to you, what are the limitations of the condition, and how can you continue to do the things that are important for you in light of this condition. Doesn't mean do not resuscitate, doesn't mean comfort care. It's just adjusting to a different way of life with this chronic condition.
Skip ahead just a little bit here because what happens when families and doctors disagree on end-of-life calls?
And it indeed does happen. Hospitals do have bioethics committees or ethics committees, which are individuals who are, when I say disinterested parties, meaning that they are not the primary caregivers. The primary nurse, the primary physician, anyone, any specialist that may be on the case, as well as the next of kin or the interested party of the family, and sometimes it may be the family member, will participate in a conference with other individuals, spiritual care, legal, other medical professionals, nursing professionals, palliative care, and talk about the case and think about 4 things. What is most beneficial? What is in the interest of justice? What is in the interest of respecting your autonomy? And what is in the interest of respecting what your wishes were? And that's an important piece. One of the questions that we fundamentally ask, one of the first questions we ask in an ethics committee is, did Mr. Bagwell ever say what he wanted or didn't want? Because if you say that I never wanted this, etc., but family wants, the medical profession doesn't, that has a lot of weight because it is being true to what it is that you wanted, fidelity. So those are the things that we consider. And one of the prime tenets in medicine is first do no harm. So we have to think of what is most beneficial and what's not beneficial for you.
I hate to even bring this up, but this is the world we live in. Is cost ever a consideration in any of these conferences?
That's an excellent question. Justice is really is one of the things about cost. You do have to consider that in terms of balancing the resources that we have for all versus the resources for one. It's not rationing, but we do have to consider cost of care and cost of care after an intervention.
And not just cost for that patient, but costs spread around.
Correct.
You made the good point. So someone's been watching. We've got just about a minute and a half left. Someone's been watching and says, yep, I'm ready to get started on this. Is important work. I need to get started. Where would you advise they begin doing so?
First, you can search the internet, look for LaPOST. You can look for 5 wishes, or you can just also just start having the conversation with your family. Say, this is what I want, this is what I don't want, this is what I'm not sure that I want. Talk to your spiritual advisor, talk to your family, talk to your physician. Those are the important people that you need to talk to, those that are in your village who will be taking care of you, and those who would come to your bedside in the event that you have an irreversible condition or can't speak for yourself.
I've done that. Now I've got the paperwork. What do I do with it?
Bring it to your doctor, bring it to the hospital where you work. Make sure that your family members have it. That is a critical piece, even though...
Talked about that earlier. The family member didn't even know about it.
Exactly. So the family member that's in California, make sure that they get it, and you file a copy. And again, you can also invest in the service that Louisiana has that you can file with the state.
All right. 30 seconds left for some take-home points.
Have the conversation. Don't be afraid of it. We're all born. We're all going to die one day. Love your family, and think about what it is that you want to direct us to do in advance. Advanced directives.
I've asked you a couple of tough questions. I'll give you one to ask me next time you're back, and I hope you are. Tom, have you made out your advanced directives?
I will exactly do that.
Very good. Thank you so much.
You're
Wonderful
welcome.
guest, great topic. Thank you so much. I want to thank Dr. Michael Boucree for the education and information he's provided tonight and for his work in the Ochsner Health System. To make an appointment with any Ochsner physician, including tonight's guest, or to register for any of our Ochsner's Hello Health seminars, they take place almost every week across the greater New Orleans area, you can call Ochsner at 504-842-5669. That's 504-842-5669. Or you can email us to hellohealth@ochsner.org. As a reminder, you can rewatch tonight's presentation to go over the details again, or any of our Hello Health programs on our website at WLAE.com or on Ochsner's website at ochsner.org. Our thanks again to tonight's guest, Dr. Michael Boucree. Thanks to Humana and Ochsner for making our program possible. And our final thanks, as always, is to you for your support of our program, Hello Health, and our station, WLAE. See you next time.